Hey everyone. So for my clinical case review, I'm going to be talking about a patient of mine that I was actually able to care for pretty much independently the other day, which was very cool. Um, so I'm at Springfield in the cardiac ICU, but this particular patient was not a cardiac patient. We were covering down for um, some other ICU patients because we didn't have any cardiac patients that night. So this patient had been admitted for septic shock. They had cellulitis on their lower extremity, and that caused an infection, which turned into sepsis. The sepsis was pretty quickly cleared up, and this had been like 2 weeks before I cared for her. And for whatever the reason, that caused respiratory distress and it led to respiratory failure. So because of that, she was intubated and extubated a couple different times, um, which she didn't tolerate BiPAP in between or anything like that. So she was really struggling respiratory wise, and what it was her lungs were just she was 77, history of COPD, diabetes, AFib, um, anemia, and just with the sepsis, her lungs just couldn't handle what was going on in her body. Um, so when we had her, she was extubated, and they were trying to wean her off of these higher levels of oxygenating, and they ended up having her on a heated high flow. Um, and so she still had some diminished lung sounds and things, but she was oxygenating well, running at about 30 liters on, I believe we got her down to 40% by the end of the shift. And so that was very positive to see that she was getting better. Um, and we actually had to transfer her down the hallway just to another room on the unit later in the morning, and we just had her on nasal cannula because you have to have high flow plugged into the wall, and she was still satting up in the 96s just on 6 liters nasal cannula. So it was very promising. I'm very hopeful for her. She had a very productive cough, which was also very helpful. Um, the shift before us told us that she had bronchi, and we didn't see any of that. So what we were doing for her was essentially monitoring her respiratory status. We were trying to wean her down slowly throughout the night to see what she would tolerate, what her lowest toleration was, which we did get her down. I believe she was at 55% when we started. We got her down to 40, and we were considering getting her off of the high flow entirely, but that was going to be a day shift problem, so we didn't do that. And respiratory was definitely involved. So she had Q4 AccuChecks, and she was ANO times 4. It was actually really cool. Day shift had a lot of problems with her and was basically like, hey, you're going to have to Ativan this patient. But we were able to give her care that was caring and patient, and we had no issues with her throughout the whole night. She was a very good patient to have. So it's just cool that, if you're patient, a lot of times patients will be patient with you. She also had a urinalysis come back that day with yeast in it. So that was a little bit of a concern as well. We were keeping an eye on. She had antibiotics running for that. So, we want to be careful that we're not like overloading her with antibiotics. We don't want to cause a C. diff infection or anything like that because she had been on plenty for the sepsis. So we're careful with starting her on it again, but we needed to be sure that the yeast infection didn't take off. So when we first got on shift, she was a little cyanotic, but that we were able to solve that pretty quickly. We kept her warm, and she was able to resolve the cyanosis pretty well. And by the end of the shift, she was back to having pink nail beds and fingertips and mucous membranes. So we were very happy with that. She had a 3-lumen central line in her left subclavian. We just had a maintenance normal saline, and then we had lactated ringers with 5% dextrose running, and that was ordered to stop earlier or later that morning. So a few of the medications we had going forward, we had 650 of Tylenol, PRN. We ended up giving that for some pain, some chronic pain that she had from throwing out her back. And also to try and break a fever, she was running a bit of a fever up in like 101.5 area. We were able to get that down to just under 100 by the end of the night, so that was good. Um, we gave her 40 of Lasix to try and clear up her lungs a little bit. She put out quite a bit after that. We actually had to Foley her because, Lasix, and then she was retaining urine as well. So as soon as we Foleyed her, we got about 1,400 right out. And I've not seen that much come out of somebody's bladder at one time. It was actually really impressive. What else did we give her? Let's see here. We gave her Robitussin to try and clear up her lungs. You know, we didn't really. She had congestion. I mean, she had a productive cough. It's hard to tell really what that was from. She doesn't have a history of heart failure or anything. But between the Robitussin and the Lasix, we were hoping that would clear up pretty quick. Let's see if there's anything else. We had her on short-acting and coverage and long-term insulin for her diabetes, so we were adjusting that Q4. And then we had to replace with 40 of potassium on an IV drip in the morning because her potassium was starting to trend a little bit low. I mean, she was on Lasix, so that's somewhat expected. Her blood sugars were trending down as well. They started up in the almost 200s, and we had her down to 129, which didn't require any coverage. So that was also very promising. And she was, like I said, a very sweet lady, very easy to work with, but a little bit more of a complex case to handle on my own, and I did appreciate that opportunity. But like I said, she was looking on the up and up, and so I hope that next time I go back, she won't be there. But so that's about it. So thanks for listening.